Welcome to this instructional video dedicated to the ultrasound study of the metacarphalangeal joint of the thumb. First, we will review the anatomical structures located on the dorsal side of the thumb's metacarphalangeal joint. In this anatomical illustration, with the radial edge on the left and the ulnar edge on the right, we can see the tendon of the extensor pollicis brevis inserting at the base of the proximal phalanx, the tendon of the extensor pollicis longus inserting along the dorsal edge of the distal phalanx base, and the dorsal recess of the metacarphalangeal joint cavity. We will now proceed with the ultrasound demonstration. First, we will examine the dorsal edge of the thumb's metacarphalangeal joint. To do this, the patient's hand is positioned neutrally on its ulnar edge. We begin with a longitudinal scan of the metacarphalangeal joint. In this view, we can observe the dorsal cortices of the proximal phalanx and the head of the first metacarpal. Superficial to these structures in the echogenic dorsal synovial recess, where we will look for the joint effusion or thickening of the synovial layers. Superficial to these structures, we can observe the distal insertion of the extensor pollicis brevis tendon. To view extensor pollicis longus tendon, the probe needs to be moved ulnarly. Here we can visualize the extensor pollicis longus. We can also examine the dorsal edge of this joint in an axial view. In this view, the extensor pollicis longus will be on the ulnar side and the extensor pollicis brevis on the radial side, superficial to the head of the first metacarpal. The distal insertion of the extensor pollicis brevis is less easily visualized in the axial view than in the longitudinal view. The sagittal band can be seen peripherally and on either side of the extensor pollicis brevis. We have now completed the examination of the dorsal aspect of the thumb. Here is an anatomical illustration of the structures visible in the lateral view of the thumb's metacarphalangeal joint. In this simplified diagram, we can see the distal insertion of the abductor pollicis muscle and tendon on both the phalanx and the radial sesamoid, with the radial collateral ligament positioned deeper. We will now move on to examining the radial edge of the thumb's MCP joint. The patient's hand can be positioned with its palm facing upwards, making the radial edge of the thumb easily accessible. By positioning the probe almost in line with the thumb, with a slight palmar tilt, we achieve a longitudinal view along the fibers of the radial collateral ligament. We are now examining the main bundle of the radial collateral ligament. The accessory bundle can also be visualized by performing a nearly axial scan. When a collateral ligament injury is detected, dynamic testing can be performed. To do so, the examiner grasps the thumb's metacarphalangeal joint with the thumb, placed on the ulnar side, and the index finger on the head of the proximal phalanx. By applying tension to the radial collateral ligament, we can check for ligamentous diastasis. We have now completed the examination of the radial edge of the thumb's MCP joint. Next, this slide illustrates a case of proximal injury to the radial collateral ligament. A hypoechoic disruption of the fibrillar structure is visible as the proximal attachment of the radial collateral ligament on the head of the first metacarpal. The yellow dotted line highlights the double cortical sign, indicating avulsion of the fibrocartilage to which the ligament attaches. Dynamic testing and tensioning of the radial collateral ligament clearly reveals, in this chronic rupture, some scar ossifications and ligament laxity. This concludes the clinical case illustrations of the radial edge. We will now demonstrate, on this simplified schematic medial view of the thumb, the structures observable on the ulnar side. Superficially, the distal insertion of the abductor pollicis brevis, and deeper, the ulnar collateral ligament, which runs obliquely from the dorsal to palmar, extending between the head of the first metacarpal and the base of the proximal phalanx. We will now proceed with the demonstration of the ultrasound examination of the ulnar edge of the thumb's MCP joint. A longitudinal scan will allow to analyze two structures. The first is the ulnar collateral ligament, which spans from the head of the first metacarpal to the base of the proximal phalanx. This is the main bundle of the ligament, superficial to which a thin aponeurotic structure can be observed, corresponding to the aponeurosis of the abductor pollicis brevis. To enhance its visibility, gentle flexion-extension movements of the thumb's interphalangeal joint can be performed to observe the aponeurosis moving over the ulnar collateral ligament. When there is an ulnar collateral ligament injury, the aponeurosis movements may be hindered, often due to retraction of the proximal ligament fragment, which tends to form a bundle beneath the aponeurosis. The accessory bundle can also be visualized in a nearly axial view. To do this, a slight extension of the thumb can be requested or performed manually, creating tension in the accessory bundle. Another dynamic test involves tensioning the main bundle of the ulnar collateral ligament by moving the thumb and index finger in this manner to open the ulnar side of the joint space. We will now illustrate ulnar collateral ligament pathology and this typical case of retracted ligament rupture presenting with a Stener effect. In this ultrasound scan, along with the ligament's long axis, with annotation, a proximal hypertrophy of the ligament can be observed, forming a bundle beneath the abductor aponeurosis. There is also an echogenic line marking the boundary of the distal stump. In these transverse scans, the proximal stump is clearly visible, retracted cranially beneath the abductor aponeurosis and superficial to the neck of the first metacarpal. Dynamic testing and tensioning of the ligament allow for visualization of the distal stump's movement and the ligament's laxity. The dynamic examination, with flexion-extension movements of the thumb's interphalangeal joint, effectively shows the restricted movement of the aponeurosis over the ligament injury, with the proximal stump forming a bundle that blocks the aponeurosis movement. This concludes the two clinical cases illustrating ulnar collateral ligament injury and brings the study of the linear border of the thumb's MCP joint to close. We will now use these diagrams to review the anatomical structures of the palmar side of the metaphalangeal joint. Deep within the digital canal, we see the flexor pollicis longus tendon in this palmar view, along with the thumb's pulleys. We will focus on the A1 pulley, which is implicated in trigger thumb, and appears in the form of an arch. In this axial view, superficial to the flexor pollicis longus tendon, We can now proceed to examine the palmar aspect of the metacarphalangeal joint. With the patient's palm of the hand facing upwards, an axial ultrasound can be obtained, allowing for observation of the two sesamoid bones. The ulnar and radial sesamoids are visible, with the palmar plate situated between them, as well as the flexor pollicis longus tendon, superficial to the flexor tendon. We can see the arch structure of the A1 pulley. The pulley and tendon can also be examined in a longitudinal view. This view further allows for dynamic maneuvers through thumb flexion and extension, helping to better distinguish the A1 pulley superficially over the tendon. The examination will focus on detaching any thickening of the pulley and fusiform tendinous thickening of the flexor pollicis longus tendon proximal to the pulley. Dynamic testing will also help identify any catching of the tendon within the digital canal beneath the A1 pulley. We have completed the examination of the palmar aspect of the thumb's MCP joint. We can now illustrate with two video loops the pathology of the flexor pollicis longus tendon and the A1 pulley. In this first loop, the tendinous thickening of the flexor pollicis longus proximal to the A1 pulley is visible, along with the thickening pulley itself, which obstructs the tendon's passage beneath it. In this second loop, we are fortunate to observe the triggering of the tendon in real time as the pseudonodular thickening of the tendon is forced beneath the pulley. This concludes the clinical case. We will now review the muscles that compose the thenar eminence. The best landmark is the flexor pollicis longus tendon, which delineates an ulnar compartment. Within this compartment, we find the abductor pollicis with its transverse and oblique heads, which generally insert from the third metacarpal to the ulnar sesamoid and the ulnar side of the proximal phalanx. On the radial side of the flexor pollicis longus, we find the thenar eminence proper, where we find the abductor pollicis brevis and the opponens pollicis muscles on the radial end, along with the flexor pollicis brevis, with its superficial and deep heads located above the flexor pollicis longus. Notably, the deep head of the flexor pollicis brevis belongs to the ulnar compartment. This annotated panoramic ultrasound scan effectively illustrates the division of muscles on the ulnar and radial sides of the flexor pollicis longus tendon. Let's move on to the ultrasound demonstration. The final chapter of this ultrasound study will focus on examining the thenar eminence. To do this, the probe is positioned perpendicular to the long axis of the thumb, and the simplest ultrasound landmark is to use the flexor pollicis longus tendon. On the ulnar side of this tendon, by moving the probe ulnarly, we can observe the oblique and transverse heads of the abductor pollicis muscle, located superficially over the second and third metacarpals. Its distal insertion can be somewhat difficult to visualize. Sometimes, by asking the patient to supinate the hand slightly, can help locate the distal tendinous layer of this tendon as it inserts on the ulnar sesamoid. A longitudinal view on the ulnar sesamoid may also be helpful, allowing for a clearer visualization of this tendinous insertion. On the radial side of the flexor pollicis longus tendon lie the true thenar muscles, of which there are three. The easiest to locate is the abductor pollicis brevis, positioned as the most radial. Typically, it is also the most proximal, originating almost at the distal end of the carpal tunnel. Its distal insertion was previously demonstrated in the study of the radial side of the thumb. The opponens pollicis does not have a tendinous insertion. It is located deep to the abductor pollicis brevis and attaches in a wrapping manner around the first metacarpal. When aligned in the long axis, a very small tendinous layer can still be observed at the head of the first metacarpal. Next, we encounter the flexor pollicis brevis, which has two heads, a superficial head and a deep head. An important anatomical detail to note is that the deep head belongs to the ulnar nerve region of the hand, while the superficial head corresponds to the median nerve region. The deep head wraps around the deep side of the flexor pollicis longus to join the superficial head, and both heads insert onto the radial sesamoid. This insertion can be highlighted in longitudinal scans like this, which also allows the observation of one component of the sesamoid sling, the radial sesamoid phalangeal ligament. We have now completed the detailed examination of the muscles of the thenar eminence. We can illustrate thenar pathology with the case of this rugby player who presented with a painful swelling of the thenar eminence and the dorsal and radial border of the metacarphalangeal joint. In these longitudinal scans, a hypoechoic alteration with the flexor pollicis brevis muscle can be observed, along with some millimetre-sized bony debris. This corresponded to an avulsion of the distal insertion of the flexor pollicis brevis on the head of the first metacarpal, illustrated here in this loop by the double cortical sign. This concludes the clinical case. This also brings our ultrasound overview of the fingers to a close, and I hope you have gained a solid understanding of the anatomy and ultrasound imaging of the fingers, mastering it right to your fingertips.